Welcome to our 11th video in Rapid Interpretation of ECG series. Topic of today's video is acute ischemic changes on ECG. The ECG is like a window into the heart, revealing its electrical activity in real time. But did you know that a heart attack doesn't just appear out of nowhere? It starts deep inside, in the most vulnerable layer of the heart, the endocardium. Today, we will break down how ischemia evolves, how it distorts the normally flat ST segment, and how to spot the telltale signs of a heart attack using a systematic approach. By the end of the session, you'll be able to identify ST segment changes, recognize reciprocal patterns, and confidently diagnose a STEMI. Let's begin. The ECG leads and their corresponding heart regions. Imagine the heart as a car, and the ECG leads as security cameras placed around it. Each camera gives a different perspective, helping us pinpoint exactly where the problem is happening. Let's break it down. The inferior wall of the heart is represented by leads 2, 3, and AVF. It is supplied by the right coronary artery. Think of this as the underside of the car, monitored by cameras placed low. The lateral wall is represented by leads 1, AVL, V5, and V6. It is supplied by the left circumflex artery. This is like the sides of the car, watched by cameras on the left and right. The anterior wall is represented by leads V1 to V4. It is supplied by the left anterior descending artery. Imagine this as the front of the car, covered by cameras facing forward. The septal region is represented by leads V1 and V2. It is supplied by the proximal left anterior descending artery. This is like the engine compartment, monitored by cameras focused on the center. So, when we see changes in a specific group of leads, we know exactly which area of the heart is in trouble. How ischemia begins and causes ST segment changes. A heart attack does not happen instantly, it starts silently. The first part of the heart to suffer is the endocardium, the innermost layer. Why? Because it is the last to receive oxygen-rich blood and the first to be deprived when a coronary artery is blocked. As ischemia progresses, the normally isoelectric ST segment begins to shift. This shift occurs because injured cells leak ions, disrupting the electrical balance. The ST segment, which normally sits flat like calm water, starts to rise like a wave, signaling an acute infarct. The criteria for ST elevation are as follows. In the chest leads, which include V1 to V6, ST elevation must be at least 2 small boxes, or 2 mm. In the limb leads, which include 1, 2, 3, AVR, AVL, and AVF, ST elevation must be at least 1 small box, or 1 mm. The changes must appear in at least 2 contiguous leads, meaning neighboring leads of the same territory. But remember, not all ST elevation is due to a heart attack. In pericarditis, for example, the ST elevation is saddle-shaped, unlike the dome-shaped elevation seen in ischemia. This is an important clue to differentiate between the two conditions. Reciprocal changes and the mirror effect. Think of a seesaw. If one side goes up, the other must go down. The same happens on an ECG. When ST elevation appears in leads facing the infarcted area, the opposite leads show ST depression. This mirror effect helps confirm an infarction and rules out benign causes of ST elevation. For example, in an inferior STEMI, where ST elevation is present in leads 2, 3, and AVF, reciprocal ST depression appears in leads 1 and AVL. In an anterior STEMI, where ST elevation is seen in leads V1 to V4, reciprocal ST depression appears in the inferior leads, which include 2, 3, and AVF. This mirror effect is a key feature of acute ischemia and helps differentiate it from other conditions like pericarditis, which lacks reciprocal changes. The final diagnosis and systematic ECG interpretation. Now, let's tie everything together in a step-by-step approach to diagnosing a STEMI on ECG. Step 1. Look at the ST segment. Is it elevated? By how much? In which leads? Remember, in chest leads V1 to V6, ST elevation must be at least 2 mm, and in limb leads 1, 2, 3, AVR, AVL, and AVF, it must be at least 1 mm. The changes must appear in at least 2 contiguous leads. Step 2. Check for reciprocity. Do opposite leads show ST depression? This mirror effect confirms that the ST elevation is due to a heart attack and not another condition. Step 3. Identify the infarct territory. Is it inferior, anterior, lateral, or septal? Use the lead groupings we discussed earlier to pinpoint the affected area. Step 4. Correlate clinically. Is the patient experiencing chest pain, sweating, or shortness of breath? A STEMI diagnosis is not just about the ECG, it's about connecting the dots between the ECG findings and the patient's symptoms. Step 5. Consider differential diagnoses. Could this be pericarditis, early repolarization, or another mimic? Remember, in pericarditis, the ST elevation is saddle-shaped, unlike the dome-shaped elevation seen in ischemia. If the first ECG is inconclusive but clinical suspicion is high, repeat the ECG every 10 to 15 minutes to monitor for evolving changes. Conclusion. Mastering ECG interpretation is not just about memorizing patterns, it's about understanding the story behind each electrical signal. The heart speaks, we just need to listen. Practice interpreting ECGs regularly, and challenge yourself with real cases to build confidence. Every ECG you interpret brings you one step closer to saving a life. Stay sharp, and always trust what the ECG is telling you.